Good morning, Bernadette. How are you?
I'm well, Alvy. How are you?
Very good. I'm going well. I'm going well. And good morning, good evening, good afternoon to everyone out there who's currently tuned in to episode 1 of the Patient Experience channel. Really, what we wanted to do with this channel was to have a conversation about patient experience, share some learnings with people who are out there implementing strategies to improve patient experience, particularly in Australia, but also around the world, and just share some key learnings that we've got at a very practical level in terms of case studies that have worked or have not worked, so that managers in healthcare, directors, CEOs in healthcare can make their organizations more patient-centered. So today we want to talk a bit about some tools and some case studies that leaders can use to sort of bring across patient experience. My name is Dr. Avi Ratnanason. I'm the CEO of NHS, and we're an organization that specializes in improving patient centricity in hospitals and also customer centricity in other private healthcare organizations. And today I've got Bernadette. Bernadette Brady is a consultant and a trainer, is very experienced from partnering with patients. And Bernadette, do you want to just tell the listeners a bit about yourself and your background?
Thanks, Avi. My background, I always have to start my background with growing up, because I actually grew up. My parents had a grocery shop and we lived it behind that. So I wasn't very old when I realised the importance of happy customers. And I took this knowledge into my nursing career. So I was a nurse for many years, and as a young nurse I always enjoyed listening to the stories that patients told, because I felt I got to know them better through their stories. And later as a midwife, I learned a lot from birthing women, being with them as they laboured and birthed, and I was always in awe of what they could do. I learned very early, though, in my midwifery career that language was important. The language of midwifery in those days consisted of many words such as incompetent, when referring to a cervix, or false labour, or failed forceps, and the language had a really detrimental effect on the women. It was very judgmental, although for the clinicians it was normal language. So I then spent time, I actually got to work with families in their own homes after birthing, and that gave me insights to what it's like for families at home. And so it actually showed me that this care that we provide in a hospital is such a small part of a person's life, and that they have this wonderful life that goes on outside in the community. I spent some time as a manager in midwifery before moving to various positions in state health, government health and general practice setting. And it was while working in the GP setting that I really started to think about the circle of life and just how small the impact of hospitalisation, or how small the time is that people spend in hospital. And yet when you're working in hospital all the time, your perception is that this is the most important time, but it's not. And it also taught me about language. I was talking to one husband, and he was in an ED. He was telling me about being in ED with his wife who had a catastrophic head injury, and somebody said, you will need to talk to the registrar. And he was a football coach, so he said, well, what do you mean I've got to talk to a registrar? Because to him a registrar was somebody who registered players. So once again language came in, and started thinking about that.
So it's very interesting. I remember so you know, when I was working on the wards in public and private hospitals, and you know, being that physician, doctor, being that registrar, and I could only see it from when patients were in the ward. I had a lot of patients to see. Time was short, so it was really more about me getting my job done than trying to figure out, well, how is this language? Obviously, we feel we're patient-centered, and we're trying to communicate in the way that we understand. And what's easy for us is the language that we learned in medical school, right, and the terminology that we had. But it's only, I suppose, when leaving clinical care and actually then seeing, oh, well, this is the gamut of a person's health, and bringing it back to myself, that I realized, oh my gosh, there's such a big disconnect. So yeah, coming back to your hospital experience, I can really resonate.
Yeah, and it's that, and I see it so often that within that hospital you have your routines, and probably say it more than once, is that our routines are built around clinicians. They're not built around the patients. And so therefore we don't actually take the patient's perspective as often as we possibly should have. And there was one experience I had when I was working with GPs, and it was an elderly woman on an aged care ward, and she spent a lot of time crying out. She was really quite distressed, and I went back to the GP, and the GP said she was actually a prisoner of war. And when she was captured, she worked in a hospital, and she was not treated well by her captors, and her husband met her in that hospital, and he promised her that he would never allow her to go back into a hospital again. And here she was in a hospital, terrified, not speaking the language, with staff who didn't understand. And once the staff knew that, which is what the GP knew because he is in the homes, in that community setting, they could show much greater compassion towards this woman. So I think that understanding of what goes on outside is really important to have. So anyway, I studied change management because I thought there has to be a different way to do this. Change management so often looks at systems management, though. For me, I've realised that I'm actually more interested in human-centred change, not systems redesign. So I worked for a while in a systems redesign team in the local hospitals. But once again, the patient's voice wasn't evident. We certainly engaged with a consumer group who supplied us with, there were people, consumers who wanted to be involved, but they hadn't had experience of the particular journey, and I felt we needed to have that experience. So we started listening to patients' experiences and gathered about 100 stories, and that then informed the changes that we made. So that's just a brief synopsis of where I started and how I've come to with my thinking.
It's very pertinent what you're saying, and we'll talk through some of the tools that are currently being used to capture that patient experience on the wards in real time, and to feed that back to managers and patient experience managers, and certainly now the world has certainly moved along in that space, but by and large where most hospitals are at in terms of systems improvement, etc., is still at that relative infancy of building the patient voice into how we manage on a day-to-day basis. I mean, we're starting to see a lot of change in Australia, obviously, with what we call Standard 2, one of the 9 quality standards that we have in Australia, of course, and that Standard 2 is around partnering with patients and getting patients sitting on committees, getting patients sitting on board level, getting patients involved at frontline level in some way. So we're starting to see that engagement happening, but it's still not very sort of integrated into the whole systems of how things work. What do you think, Bernadette?
And I think that we've had this conversation before, that for me, it's almost a token effort, a tick the box, bringing patients in and sitting on committees, because invariably we'll bring one patient in to sit on a committee that's where they're surrounded by clinicians and hospital staff who once again are in their own environment. I always think as a child I was incredibly shy. Take me outside of that shop, I would just hide in my father's shirt collar because I was so shy. Put me in that shop, which is the environment I knew and where I felt safe, and I was the boss. Even as a 5-year-old, I knew what I could do and where I could go and where I could get a drink of water and where I could have lunch. We bring consumers in, we bring them in one at a time into almost enemy territory, and we have to stop doing that. We have to bring them in and show them equal. So if we're going to have a committee, you don't bring in one, you bring in at least 2, preferably 3 or 4 people. And I think that then we really start to respect the expertise that these consumers and patients can actually bring to the discussion, because they do have a real expertise. I think about a woman who was actually an executive director of nursing, and she told me about being a patient in the hospital where she was working, and she said, the cleaners come in here and they do the sign of the cross. And I said, what do you mean they do the sign of the cross? And she said, well, they walk in and they mop here, and then they turn around and they mop there, and then they walk out and they think they've done their jobs. The basins are dirty, the floor's dirty. That's what patients see, and that's what they bring to the discussions. So, we are moving along, but we're not for me, we're not moving fast enough. We've had consumers on committees for a long time. We now need to acknowledge that they have an expertise that is different to ours, but is just as important.
Yeah. And certainly, I think, Bernadette, as we're talking, one of the things that you and I both discuss is looking at that whole patient journey from a holistic perspective, as you've talked about. And I've just got a little slide here that talks to that, which is around that whole concept of patient journey analysis, looking at the whole journey from admission to either if it's a surgical patient to operating theater to inpatient ward to discharge and the billing. I mean, I've spoken to hospitals and in some hospitals, but in the private sector, the billing and discharge process, obviously private's got billing, but public's got the discharge process, is one of their most traumatic times. And I was starting to think about, well, why is that? And there's something happens with our mindsets when we're a patient, from the time that we're receiving care to the time that the doctor or the nurse says, you're ready to go home. And after that, time just changes in your mind. From having stayed a whole week or 2 weeks in the hospital, suddenly every hour in the hospital is too long. From the time that it says you're ready to go home, every hour becomes way too long. And I want to go home now. The doctor said I want to go home now. Give me my medications now. Give me my paperwork now. I just want to go home now. And so the whole patient experience suddenly just changes. The mindset, as you call human-centeredness, changes just at that point. So it's very interesting when you sit in that patient and look at that whole patient journey from that perspective.
Yeah, and I think that when we talk about whiteboards, and we use whiteboards, just to work out when patients are moving along that journey so that they understand. And for me, it's about, if you don't have my mantra is 2-4 with. If you don't consistently share knowledge with patients and seek their input to it, they actually don't understand where they are on a discharge trajectory. Discharge planning is not something that patients know about. It's quite often, I have found, something that medical people don't realise, that those two words go together. I've had a doctor that I've spoken to about discharge planning. He's just looked at me and said, what is that? So, it's that you have to be moving towards this end bit. And I think about a young fellow who, Susan Bigger, is a fantastic consumer advocate in Australia. She's out of Melbourne, and she has 2 sons with cystic fibrosis, and she's written a book, The Upside of Down. And she talks about one of her sons, these boys run marathons, and they're both in their teens, one's studying in Stanford. Yet when they go into hospital, they are totally, every piece of knowledge that they know is just not of interest to the staff. And so the whiteboard was there, and he was really angry because he wanted to run. And he said, if I don't run, I don't live. I have to run, and yet these people keep coming in and arranging things with me. And Susan said to Aidan, you take charge then, and you write on the board how you want it to happen, which he did. He wrote that he was going to go for a run every morning at 8 o'clock. The physio walked in. He said, oh, Aidan, I was going to come in at 8 o'clock. That's great. You go for a run. I'll come back afterwards. The staff just automatically started rearranging their day around the patient because the patient took control. We don't often enable patients to do that. And if we enable patients to do that, we constantly do these things to patients. So we take away their ability to be in charge. And we also take away their responsibility, their level of responsibility and accountability, because each one of us is accountable for our own healthcare. Each one of us is responsible. We can't pass that on to somebody else, and yet for years the medical system has taken that. And so we've disabled patients' ability. So when it comes to discharge planning, if you haven't had the discussion and haven't made it a day-by-day process where you're explaining everything that's happening and making sure that that patient understands, the discharge it's just sort of like, yeehaw, I'm out of here, get me out. And then you have medical misadventure once they go home because they don't understand the medication changes. They don't understand what's actually happened to them. I've had somebody show me 3 weeks after he went home, show me his discharge summary and say, can you tell me what was wrong with me? he should have known that weeks, days before he went home, if not the day he went home.
Yeah, look, absolutely. I think when certainly a lot of the discharges that I did as a house officer, a lot of them were for patients I didn't know because you just had to
Yes.
do them, on the day that you were on, and the way things are moving with, shift work and trying to fit everyone in and get the work done. You're often just filling out forms that really someone else has sort of prepared the medication throughout the journey. You write down maybe 3 points of the diagnosis, and then often expect the patient to go. And it's often the GP's job after they've come out into the community to then follow up and go, okay, well, here's actually what happened to you in hospital, because that explanation hasn't happened. So certainly, I think two things that you're saying there is we definitely should ask people more during that hospital stay, how do you want to be cared for? Because quite rightly, as you point out, and remember, doctors and clinicians, we become patients too when we go to hospital, and we come in with all this knowledge. Some people are senior executives, managers, high profile, intelligent people that come into hospital or already have a lot of knowledge of their illness. And then when they come into hospital, a lot of that's disempowered because they go into the routine of us as practitioners who go, okay, now you need this, you need this, you need this, you need this, and here's my day, and here's how I structure my day, and you'll be seen at 9:15 to 9:30, and blah, blah, blah. And we never actually get into that conversation of, okay, well, how do you want to be seen, or that sort of thing. And sometimes there could be that win-win if we open up that conversation.
Yes, yes. To change from that to mentality to the with mentality, I think, is the hardest thing. And I think too, Avi, discharge planning is a team effort. It's not just about the doctors. And so I believe that there needs to be more of a focus on, okay, from a nursing perspective, is this person, where are you on your health trajectory, physios, social workers, OT, speeches? Everybody needs to be involved in that process so that it's not actually just one person. I think because so often I see what you were describing, where it'll be a resident who comes in and they're busy. Our residents, our doctors are so busy, and yet we make it harder for them because we bring them in to discharge somebody who has been in hospital for sometimes 3 months in an aged care setting, I've experienced. How do you put all that information together? You don't. You can't. It's just impossible. And so we're setting the patients up for failure by not consistently just keeping up that process, having that conversation, allowing them to understand where they're at, so that by the time they go home, they're still in charge of the information, whether it be the patient or the people who are caring for the patient. But they actually have the same understanding that we do. We have to take the time to do that and to show them that we don't just care for them, we care about them.
Yeah. Bernadette, what are some of so, in a lot of things, and again, obviously there's some things that we're putting in place on the wards now, just at ward level. You talked about the whiteboards. Some wards in hospitals, for example, have got whiteboards that mark certain metrics that they want to look at, and some of those metrics are even the patient satisfaction or patient experience score. In the NHS, they do that now on some of the wards. How is this ward scoring from a patient perspective? But what have you seen in some of the hospitals that you've worked in that have made improvements? What they do well? What could they do better? What are some of the examples that you've had?
I would have to say that the simplest thing there's two things that I would love to see happen in hospitals, and that is that everybody introduces themselves. So simple. Good morning, I'm Bernadette. I'm your nurse, I'm your whatever. What can I do for you today? So you actually give that little bit of understanding, and to smile. It is so easy to smile, but you walk around hospitals and people I know they're totally focused on where they're going from A to B.
Yeah.
I walked into a hospital one day and there was a woman walking out, and I was walking, and I smiled at her and said, "G'day, how are you?" Kept going. I met that woman probably 8 months later, and she said, "I remember you." And I had no idea who she was. And she said, "I remember you. You smiled at me the day my husband died." I was leaving the hospital. I'd been there with him for weeks, and he'd just died, and I had no idea where my life was going, and I still don't know. But I know it was you, and I know that I will be grateful to you forever. I get emotional when I think about that woman. I have no idea who she is, but I think that's how simple a difference a smile can make. So please, if I can say to people, please smile. So simple.
I think that's such an important thing. We did a project with a GP clinic in the UK, and one of the problems that they were having was that they had a high percentage of patients not attending the clinic. And the solution that they put in place, and so obviously when patients don't attend, you've got full GP clinics, and when patients don't attend, it just throws the whole day out of order, and they've got to reschedule everything, a lot of work. So the solution they put in place was they put a sign up on the door that said, this week 32 people did not attend the appointments, so please don't do this because it doesn't work. And so they put that sign up, and what happens after they put that sign up was that more people started not attending, did not attend, or DNAs as they call them, because I think what went through what the psychology of people was that, last week 32 people don't attend, so if I don't attend, it's just 33, it's not a big deal, so it's not a big problem, not attending. And that was a solution that obviously didn't work and made the problem worse. So we actually went in there, and we actually did some analysis of GP clinics, the patient journey, and we did very deep emotional analysis. So what's the emotions that patients go through when they come into a general practice clinic? And once we did that analysis, we found that there were two emotions that were most underserved when someone comes into a clinic, and that was, one was control, a sense of control, or empowerment, disempowerment, and the other one was respect. Right? So there's no control, there's no respect. So we said, okay, what are the simple things we can put in place to change that emotional paradigm? And there's two things we did. One was, as you said, we trained the receptionist to smile every time, consistently. Just smile. When a person comes in, smile. And I think if you've been to a general practice clinic, how often we don't smile is just phenomenal, compared to anywhere else. We're so busy. But just forcing people to just smile every time. And the second thing we did was we changed the power paradigm, so that control paradigm. So when you make that appointment with the GP, instead of us going, okay, your next appointment is at 2:40 on Saturday. Okay, that's fine. Boom, give them the card. We changed it around, and we gave them the card. So we trained the receptionist to give them the card, gave them the pen, and write down the time that they wanted for the appointment. So we switched that paradigm. As a result of doing that, in 6 months, we reduced that do not attend rate reduced by 40%, just by those two measures, and that was sustained over a 6-month period. And how much did that cost? How much did that solution cost? Right, really, hardly anything. And sometimes I think that we spend a lot of time in healthcare thinking, oh, we can't fix this problem. It's going to cost too much. It's going to cost this. We're trying to save money, blah blah blah. But really, what we haven't done is just get into what the patient really needs and wants. And if we do that, the solution can be very simple and very cost effective. Do you agree with that? Yeah.
And it saves a lot of anger, because I have done a lot of work around clinics and timing and looking at when the most complaints are occurring, and invariably by the end of the day the complaints are going up because the staff are getting tired. But you have to actually find out how it is. There was one woman that I can remember who arrived late at a clinic, and the receptionist just said, no, you've missed your appointment. You have to come back in 3 months. She had travelled for something like 8 hours on a bus to actually make it to that appointment with 2 little children. And it was like, no, come on, we can do better than this. This is find out why people are a little bit late or why they haven't turned up.
Yeah.
And also, is it about something that a process within the facility? Is it that the parking is inadequate, or is it something like that?
Yes.
It's something we need to fix elsewhere to make this easy. So yeah, I think that's a great solution you came up with. I very much like that story, and I hope a lot of people listen to it.
Yeah, no, absolutely.
It's certainly the way to go.
What are the other things that you've seen or feel that we could do in Australia a lot better or even around the world, what are some of the solutions that you've seen that, this works really well? Um,
I think if we're looking at Australia, and I believe we really need to look at how we manage risk.
mm,
I had this conversation recently with somebody, and I thought risk is something that we've started focusing on, and we tend to get caught up on the risk. We so often in health we get caught up in our data, and we forget about the humanness
mm,
of what we're working with. So, and I think I said earlier about I'm interested in accountability and responsibility, and I think that there has to be a recognition. We have to start to recognise that patients do need to take responsibility for their own health and what they can manage and what they can't. And that is about that expertise in our own lives again, and being able to explain and have the conversation and work out where the middle ground is. But I think we really need to look at risk, and is it because health can be such a paternalistic system that is how we so often say no to people. No, you can't do that. I've had to learn that recently with my aged mother who has a frontal lobe dementia. She's 87. She lives at home on her own. That's what she wants to do. She can still have that conversation. I very much felt that that was not where she needed to be.
mm-hmm.
And I had the conversation with her and my brother who lives next door. She's peaceful there. She's happy. If she falls, we've had the conversation about it. And she has said, if I fall, I fall. But I would rather be here because I feel that I will keep my marbles, as she says, much longer if I'm in this environment. She said, I watch people go into aged care facilities and they have an early dementia like I do, and they lose their marbles so much faster.
Mm-hmm.
So she is prepared to take that responsibility.
Yes.
I think we need to do that more instead of clinicians owning the responsibility, because I don't think anybody can own that responsibility.
Yeah.
So I guess that would be one thing that I would do.
Just on that point, yeah, just on that point, Bernadette, I think what you're saying there is really important around risk, because a lot of times when you sit in the clinician's chair, one of the decision making criteria that you have in your head is around managing that medical legal risk, right?
Yes.
And that, is it negligent if I send this patient home at this point in time? They really should be here to get, higher level intensive care, rather than sending them home. And those sorts of things start to sort of play in the minds of clinicians when having that risk conversation. And I think perhaps what we can sort of take away from that is that this is a two-way street, and the risk needs to be shared between the clinician and the patient as well. And that if it's documented that you've had the conversation with the clinician and the patient and the patient's corpus mentis, and that we they have taken responsibility if they've got family support, or will have a social worker or a occupational therapist seeing them on a regular basis at home, then that risk is managed. But sometimes we don't go into that level of depth because, again, either we're time poor or we're feeling very risk averse that we feel that we've got to take on that medical legal risk rather than sharing that risk. And I think that's a really great point as well.
Yeah. I also think we need to celebrate our successes. I don't think we do that in health. We listen to what the media is telling us or berating us about. If anybody makes a mistake, it makes the headlines. The good stories don't make the headlines, and yet I know from the various hospitals I go into that the majority of staff go to work every day to make a difference and to improve the patient experience. And we don't celebrate that. And if we look at safety and quality, we do safety and quality really well. But we actually focus on what we don't do well in safety and quality. We focus on when human error means that something goes wrong. And that's because we're human. If we learn from it, then I think the majority of consumers would say if you learn from that mistake and if you put in systems that mean it will never happen to anybody else, they're happy. But we don't then think about all the times that things have happened when nothing has gone wrong. And I think we really need to start celebrating that a little bit better. I've had some experience recently with airlines, and I think so often, we will compare ourselves to an airline, and I think they don't get it right all the time either. They certainly don't get their customer service right.
Mm.
So I think it would be better if we actually started saying, no, we've done things well. And in doing that, the other thing that I'm really very interested in at the moment is the second victim mentality, where if there is something that happens and if there is a misadventure for a patient, that the person who was present, and it's not for us to judge, but so often we will judge the clinician who was present as being guilty. They're the second victim. I would like to get more people talking about second victim, because we need to look after each other. If we don't look after each other, who looks after us? Because we are there to care for patients. And that means that we need to go home every day. Sometimes from minute to minute, we need to take a deep breath and leave a situation that is horrendous. And walk away and find another, into another situation. So if we don't actually look after each other, who will look after us? So if there is an event that has led some misadventure, an example is not slipping into my head, we need to look after our colleagues as well.
Yeah, I think there's that that element around community. So I think you're breaking it down into a couple of pieces around clinicians, and so there's one piece around looking after the well-being of our own staff and clinicians, right?
Yes.
And that's the mental and emotional well-being. We know that studies have shown that in the dental area there's high rates of suicide. We know there's some facts around that. On the medical staff, I've seen studies here, even in Australia, done by Beyond Blue, by very high rates of depression and mental illness amongst doctors and medical students. And we've seen data around nursing staff as well. So there's an element around, we need to do more in general and give clinicians, practitioners, etc., the tools to just maintain their well-being and their stress on a day-to-day level. So that's a general day-to-day thing. But on the second side, what you're saying is, when things go wrong, when there are medical errors, etc., we've got to balance that culture of protectionism that sometimes, the consumers say that there's this culture of protectionism and try to hide things, with the fact that we actually do have to care for not just the patient that's been wounded or injured or so on, but also the practitioners, the clinicians, and their mental well-being, because I know it can be very traumatic. I know I've had colleagues that have had, allegations made against them. They were later cleared, but, having to not work for 6 months, or being suspended for 6 to 9 months to 12 months because while that allegation was being investigated, can be very, very traumatic when there's nothing else you know how to do apart from being a clinician. But such is due process. I
think too, Avi, not allowing, if we talk about protectionist, I think when things happen, we are too slow to say we're sorry, or to be able to seek out the patients and say, this is what happened, this is my side of the story. Because we're so risk averse, we don't have those conversations, and so months and months can go by. Now, if a day goes by, people are getting angry, but by the time you let that lag for months while the processes and investigations are carried out, if you don't address an issue at the time of happening, we all start to make our own stories. And I think that there was a story, and I can't remember, it might have been in actually Robin Youngson, who talks about and I know what the story was. It was about a young fellow, a young lad who went in for surgery on his ankle, I think. There was no indication that there was any danger. He died, and his mother was really angry, and the surgeon never spoke to her, and she just got more and more angry. What she didn't know is that surgeon desperately wanted to speak to her, but had been instructed by the hospital that he could not speak to her. And so eventually he couldn't stand it, so he approached this woman, and she, of course, told him to go away. But he went back to her and told her his side of the story, and they now present together. And I think that's that's a really important lesson. Is there should not be any secrets. Do not have secrets. We shouldn't have secrets from each other. I work with a group that we meet on Skype once a month, and these people all work with patient and family-centred care. That's within their role description.
Yeah.
And they talk about family, and they're happy to share anything they do, except there's one person who says, my hospital does not allow me to share, and I can't share any of the information. That's ridiculous, because it's not about the hospital, it's about the patient.
Yeah, I think the barrier, or really what we need to distinguish in those instances, is the difference between confidentiality and privacy, and what is
Yes.
Best practice sharing to upskill ourselves, right? And there's a way to do that. So, in sharing, we don't necessarily have to disclose the patient's name, their geographic location, any identifying factors when we're discussing cases and how to solve cases.
No, this sharing is very much just about policies and the way that people work with patients to encourage patient-centred care. So
that's right.
The confidentiality is not there, and I think it's an area that we're all learning. And so if we can all talk about it and discuss it, new ideas, that's how innovation happens, isn't it? When we all think with an open mind and have the conversation.
Absolutely. Yeah, I feel like with innovation, what we find is we need to go broader and look at the big picture, and also go deeper at the same time and get to the very, very specifics of the issue. Really understand why the issue is happening. Really understand in the mindsets of clinicians why they think like that. Understanding why in the mind of the patient or the emotion of the patient, why that's happening. It's only when we get to that point do we create solutions. Otherwise, we tend to work off assumptions very, very often that lead to trying to solve the problem in the wrong way. I'm just conscious of time, Bernadette. We're going really well with this conversation, but probably, just to sort of wrap up, there are a couple of things that I suppose, I'd like to get your perspective on. Why do we think, why do some clinicians, I suppose, get it right and do patient experience well, and why do some not? And what does Australia need to do, and what do we need to do in this country to sort of fix those sorts of things?
That's a big question. I think getting patient experience right can be really difficult for professionals, because we're trained to find the problem and treat the problem while considering the inherent risks, and that process really doesn't invite patient expertise. But for me, it's the difference between seeing the disease and seeing the whole person. So I have a friend who is a quadriplegic. He's been a quadriplegic for 40 years. So he looks after himself at home. He lives alone. He, until recently, did all of his care alone. He cooked his own meals. He goes out to work every day, and he worked hard to keep himself in good nick. He goes scuba diving. He's probably done about 400 scuba dives, because he's got a hemangioma on his injury site, and that causes him a lot of pain. Going scuba diving gets him weightless, and so relieves the pain. He's currently in hospital. So Peter goes into hospital, and all of a sudden he's got everybody telling him how to do things. Now, he has lived with this for 40 years. He knows how to do it. He's still alive. He's a quadriplegic who at nearly 60 is still alive, and is still living fairly well. He knows how it works for him. So for me, it's about that. It's about seeing that whole person and respecting that whole person and listening to them. And for me, if we could see the whole person in everybody we care for, we'd actually be a long way. And I think that's the difference between getting it and not getting it.
Yes.
I have a colleague who is an ICU specialist who didn't get patient and family-centred care until her daughter was unwell. And she was behind the curtain with the daughter, and she was really concerned about her daughter. And she couldn't she was the ICU director in that hospital, and she couldn't raise the interest of the staff to say, I'm really concerned about my daughter.
Yeah.
And so for her, that's where she developed that passion, because she had that experience, that other side of the bed experience. We shouldn't have to have the other side of the bed experience. I do not believe that we have to experience something to show compassion to those who are experiencing.
Yeah. So until we walk
Just
in
do
that,
not believe it.
yeah, until we walk in that patient's shoes, as they say, do we really get that real insight, don't we?
I think we have to. I don't think we have to walk in their shoes, though, Avi. I think we do have to sit with them and we do have to listen to them, but I don't think we actually have to go through what they're going through, because we can't. If one person has an appendicitis and then I have an appendicitis, the treatment, the whole journey could be totally different.
Of course. Well, what I meant
Um,
was more, things have happened for my insides when I walked into hospital accompanying one of my family members, or
yes,
and it really transforms my whole thinking. When
yes,
with my late father going in to see his consultants and his sort of his operation, surgical experience and all that. I've seen things in hospitals that just blew my mind, even
yeah.
after having worked in hospitals for so many years. So what I mean is that it can really change your perspective once you're in that other.
And I often wonder if that's about mindfulness, because when we're working, we don't stop. We actually see things through a different eye when we are there with somebody we love,
Mm,
because we want them to have the best possible care.
yeah,
And we're actually sitting. We actually have time to sit and observe what's happening. It's like that executive director of nursing who saw the sign of the cross, that can do the sign of the cross. We actually see things differently.
yeah,
And you actually, one of the things that I've done with staff, and it always just blew their minds, was say, I want you to walk through your ward with a video camera, because what that does is actually brings them down to that lens, so
yeah.
they don't see the hole. And they would come back and they would say, oh my God, there was one ward I worked in, and there was a pair of trousers hanging up in one of the storerooms with a hanky still hanging out of it
Mm,
and a belt. And when we went back, they said, how long have those trousers been there? And I said, those trousers have been there as long as I've been coming into this ward, which at that stage was 6 months. They had not moved.
yes.
But when we went back, there were people who could remember those trousers being there 5 years
Mm,
before.
mm,
So of
mm.
course we got in and cleaned up the storeroom. But it's that stuff we don't see what we look at every day. And I guess for me, I call it the new normalization, but I guess it's the habitual. That when you see things every day, they just become your normal. I
Yes.
think about when I started nursing as a 17-year-old. I remember the first person who I saw who had died. I remember that person so well.
Yeah.
I don't remember the second person,
Yes.
because having seen the first, it became normal. So I
Normal.
think,
That's right.
there's all that stuff.
Yeah.
We've got off track. I'm sorry.
No, no, that's all great, Bernadette. I think there's really a lot more we could talk about, and I think we just wanted for this episode to hash out a lot of the ideas, and I think there's more for us to do in a second conversation, because we've really covered a lot in the time. I just want to leave the group with a couple of resources and key learnings. So we have conducted some research with some hospitals in the UK around how to manage patient experience, or making sense and making use of data in patient experience. So we have a paper at the link nhs.com/patient experience white paper. So that's available to everyone that's listening in to this video. In addition, obviously, you and I, Bernadette, we're in this group conversation called Patient Experience Australia on LinkedIn. So if anyone wants to continue this conversation that Bernadette and I have just had, and we'll be putting up this video on the group, please join the group. Join the group, Patient Experience Australia, on LinkedIn, and continue to have that conversation with us. Ask any questions there. Many other members of the group that are either experts or working in this space and learning themselves. We're all sharing ideas and learning about how to improve patient-centered care and patient experience. So this is a place for us to do that, particularly for the Australian environment, but happy to bring on ideas. And as we are from US, UK, in other Asian countries as well. So by all means, please join the group. And feel free to get in touch. Here are my contact details. If you'd like to get in touch, you have any ideas, you want to speak about a topic, or you'd like us to discuss a topic, either myself or Bernadette or somebody else that you think we should invite onto the channel to discuss patient experience, more than happy to invite them along, have a similar sort of conversation, extract some ideas that we can implement in Australia to help improve patient care and improve patient experience in Australia. But any last or final words that you want to just say to anyone that's watching this particular video?
Um, the thing I've been thinking while you were putting up your slides, Avi, was about, and I had this conversation with somebody the other day about cultural surveys and patient surveys, and I think I would really like to see a change in the way we do cultural surveys and patient surveys, because if they don't, if they take 18 months to come back, so much has changed and so much hasn't changed. And I actually want to know what people are experiencing today. I want to know what staff are experiencing. I want to know what families are experiencing. I want to know if they're getting the right care. I want to know if they're involved in the care of their loved one. I actually want to know what's happening now so we can address the issues now,
Yeah.
not the issues that happened 18 months ago. And it was funny, your slides just
Yes.
reassured me that
Thanks for bringing that up.
hope is away.
I think, what's really, as you're probably aware, we've got a few technologies to help in that area of staff surveys and cultural surveys. One of them is called Pensensic. The other one's called MES Experience. They are very advanced tools that help hospitals now. We are working with hospitals in Australia, as well as in other countries in the UK, to have this multi-channel approach to collecting feedback and survey data from the wards themselves. I think that this is something that I'm happy to take offline and have a conversation with anyone that is in the group that wants to discuss these sorts of tools and how they might help them, because there's a lot to talk about when you start getting into the tools. And maybe that's a topic for the next conversation, is getting into what can tools do in the survey platforms, etc., to help improve that process, because they are fundamental to the whole patient experience side of things. So thanks very much for that, Bernadette. Thanks everyone for listening. Here are my contact details again. Please email me, and we'll get back to you on are there any topics of interest that you'd like to talk about, if you'd like to speak yourself, or if you'd like to inquire about any of the things and ideas that we talked about, or join the group, the LinkedIn group as well. So thanks everyone. Goodbye, and thanks for listening in. Thanks very much, Bernadette, for being part of this.
Thanks, Avi. Thanks, everybody.
Cheers.
Cheers.